Good morning, colleagues. I'm happy that you're able to join us today. I am Dr. Shanti Singh Anthony, the coordinator for HIV Knowledge Management at the Pan-Caribbean Partnership Against HIV and AIDS. And I am your moderator for today's webinar on TB and HIV screening, diagnosis, and treatment, update on WHO new guidelines. This is a PANCAP webinar in collaboration with the Pan American Health Organization, and I wish to thank PAHO for the ongoing collaboration in medical education and capacity building for our healthcare workers and practitioners in the region. At this point, I will share with you, before I proceed, a few housekeeping notes. Your mics are muted. If you have any questions, please type and submit these using the chat bar that's on your webinar panel. We will take your questions during the question and answer segment at the end of the presentation. We are recording the webinar. The recording will be shared on the PANCAP social media platforms for the benefit of those persons who could not have attended this live session this morning. By continuing to be in this webinar, you're consenting to be recorded. At the end of the session, you will receive a certificate of participation. Again, I encourage you, as the presentation is going on, that you type your questions and we'll take them at the end of the session. This is our first webinar for the year, and I think that it's therefore fitting to get some remarks and to hear a little bit on PANCAP's vision and plans for 2024 from the director of PANCAP, Dr. Wendy Tegelt Emmanuel-Son. And so I therefore invite Dr. Wendy to speak with you briefly on the plans and the visions and to bring some remarks to you on behalf of PANCAP. Over to you, Wendy.
Yes, thank you. Thank you very much, Dr. Singh. Thank you for organizing this and welcome everybody. Welcome, Dr. Omar. It's certainly a pleasure to be able to be part of this webinar. This is, of course, the first one for 2024, but during the past few years, we had a number of webinars, and based on the response that we get from the region and the participants, we realized that, you know, the webinars are welcome and the information is needed and also used. So thank you for doing this and organizing and making sure that we have these webinars, Dr. Singh and Richard, our communication specialist, and also the technical persons that are available. And today we have Dr. Omar. As PANCAP, we are one of our main responsibilities is to ensure that we create that sometimes a literal platform where our partners, our healthcare workers can receive the needed information and make sure that they are updated. So that's why we are happy that we have, I think, now around 80 attendees. We have a number of webinars scheduled for the coming months, and every month we have one, the third week of each month, so you can look forward to our webinars. And we are also very happy if you join, you ask the questions when that is needed, and we are very happy to get your feedback. So welcome and thank you again, and I look forward to a very good session. And thank you again, Dr. Omar and Shanti and team. Thank you.
Thank you, Dr. Wendy Tegelt Emmanuel-Son, PANCAP Director. So as Dr. Wendy was saying, you know, there has been the request to be for PANCAP to continue these knowledge sharing sessions, be able to provide updated scientific evidence, updates on normative guidance, etc. And a lot of our attendees have been with us over the last 3 years that we have been doing this. Dr. Omar Sued, who's our presenter today, is no stranger to our attendees. Dr. Omar has presented on many occasions at our webinars and at this platform. I'll nonetheless go ahead and invite you introduce you, Dr. Omar. Dr. Omar is a medical doctor specialized in infectious diseases and HIV, trained in Buenos Aires, Argentina. He completed his master and PhD degrees at the University of Barcelona, Spain. Dr. Omar has worked as an ID doctor in different settings, including the public and private hospitals, prisons, and primary healthcare centers in Argentina and Spain. And so you can tell, very diverse and rich experience. He was chair of the 16th and the 22nd Argentina Infectious Disease Argentina Congresses and former president of the Argentina Infectious Disease Society and the Presidential Committee for COVID-19 Response. During 2009 and 2012, Dr. Sued served as advisor in HIV treatment and care for PAHO. In this position, he supported many countries, including many of our Caribbean countries, in the development of national HIV guidelines and monitored the use and coverage of ART therapy, again, for the Caribbean as well. He was part of Treatment 2.0, and I'm sure that many of us who are in the room, we do recall those days of Treatment 2.0, and the HIV and syphilis elimination initiatives. Dr. Sued served on several WHO guideline expert groups, including guidelines on PrEP for HIV and the use of cotrimoxazole prophylaxis for HIV-related infections among adults, adolescents, and children. And so I think Dr. Omar Sued is really well positioned to be able to bring us this morning the updates on the TB HIV guidelines, screening, diagnosis, and management. From 2012 to June 2021, Dr. Sued served as the research director for the foundation in Argentina, where he was involved in ART strategies, PrEP, and model of care for vulnerable population. And in 2021, he rejoined PAHO and is currently the HIV STI care treatment advisor at PAHO. I now invite you, Dr. Omar, to present to our attendees this morning on TB and HIV screening, diagnosis, and treatment, update on WHO new guidelines. Over to you, Dr. Omar.
Thank you very much, Shanti. This is a too much long introduction, and thank you, Wendy. Also, it's very nice to meet you, and I am very pleased to be with you and to continue sharing some information about the guidelines, the WHO guidelines. For me, the work that PANCAP is doing in the Caribbean is incredible, and some of the material I will be presenting here has been presented also in the NAP manager meetings in October, so maybe you might be familiar with some of those slides. I will close my camera and let's do a start. Okay. After 2 years of the pandemic, we just start seeing improvement in the program. Remember that COVID really impacted very bad in the indicators. So many people that had TB was not diagnosed, the mortality increased, the number of people tested for HIV in 2020 and 21 was reduced. So finally, we start seeing an improvement on those indicators. The last year, 80% of the people in the world had the HIV documented status. In total, in the world, 6% of the TB cases are associated with HIV, but this is 11 in Latin America. More or less 671,000 people are estimated to have HIV TB, but are really diagnosed only 450,000. So there's a big gap in identifying people with TB and HIV, and therefore only 55% of the people benefit of the impact of the TB and the antiretroviral treatment. And for this reason, we continue seeing 167,000 deaths in the globe associated to this co-infection, and 31,000 people are children. HIV infection after undernourishment is the most important factor for the development of tuberculosis, in much more than alcohol, smoking, or diabetes. But as you know, many people with HIV infection has also those other comorbidities, and so this explains the high prevalence. In the Americas, even though we have 13% of all the population, fortunately we have only 3% of the TB. In the Caribbean, there are many countries with very small epidemics that can really think about eliminating this disease. But still, 11% of the cases continue being associated to HIV. So always we need to look for tuberculosis among HIV patients and for HIV among people with suspected tuberculosis. 28% of the TB deaths are associated to HIV. In the region, this means 9,000 people dying every year. Here is the summary of the Americas. You see from the estimated people, only 58% are documented and reported by the national HIV programs and TB programs, and only 63% are receiving treatment. So these important gaps will really need to be addressed in order to eliminate the tuberculosis. And for this reason, the first recommendation of WHO is that we should be able to implement differentiated HIV care and patient-centered approach really to reach those people that are more difficult to reach. And we should engage also or to implement, in particular in tuberculosis and HIV program, an intervention to recover people that may be disengaged from care. To work with tuberculosis and HIV, the Stop TB and the HIV department in WHO proposed this set of collaborative TB/HIV activities in 2013 to improve the management of tuberculosis and HIV. And this is 3 specific goals: to establish and strengthen the integration mechanism between tuberculosis and HIV, to reduce the burden of TB among people living with HIV, and this means to really look for tuberculosis in any HIV positive patient and provide prevention for tuberculosis, and to reduce the burden of HIV in patients with probable or confirmed TB, and this means mostly to perform the HIV test. For the first goal, I mean, the organization in different programs is different. So we have some TB/HIV cases that are managed for the TB national program, because the TB national programs provide in the setting the HIV diagnosis, the HIV prevention, the cotrimoxazole, and the referral for treatment initiation. Other countries, the co-infection is managed by the HIV services, because the HIV services provide the TB prevention, the TB screening and diagnosis, and they treat or refer patients for treatment. But there are also other countries that propose these integrated HIV and TB services, in particular in the primary level of care, where tuberculosis usually is being provided, the tuberculosis services. So this is the case of Argentina, Brazil, Chile, Cuba, or Uruguay, where the same clinic that provides services for tuberculosis, the same doctor provides services also for HIV, and provide differentiated care management for iris when the patient really is complicated or complex. He refer for specialized care. In any of these different programs, one important component is to avoid that the health center become a center for transmission of tuberculosis. So any HIV or tuberculosis healthcare center should have this administrative intervention that means to triage people that can have signs or symptoms of TB to implement respiratory preparation, mask, respirator, and ventilation system. Regarding to the second goal, that is reduce the burden of TB in people with HIV, we have here in the screen the big missed opportunity for prevent tuberculosis. Look that in the Americas, the number of people receiving prophylaxis for tuberculosis is very low compared with the 150,000 people, new people receiving the HIV diagnostic every year. And this looks like it's decreasing over time. So big effort, and this was for the COVID, big effort need to be done to increase the number of people receiving prophylaxis. In particular, the new HIV cases that are HIV patients that doesn't receive antiretroviral treatment and that are more higher risk of develop tuberculosis during the first years until the antiretroviral improve the immunological system. And why HIV doctor doesn't provide prophylaxis for tuberculosis? Well, this is a fear to the resistant to TB. This fear is unfounded. There is no evidence that isoniazid produce or promote the resistance. But now with the new combined rifampicin isoniazid regimen, this risk is even much more lower. The other problem is many guidelines request to use the PPD or TST or IGRA for evaluating patients eligible for tuberculosis. We will be discussing this later in more detail. The other issue is that many HIV doctors cannot prescribe rifampicin or isoniazid because these medicine are in or need to be prescribed for the tuberculosis program in this specific center or country. So this fragmentation or lack of integration really impacts in the number of patients acceding to prophylaxis. And so we need to really to look for better and simplify screening tools and algorithm and to implement the shorter regimen to facilitate this. When we discuss who should be receiving prophylaxis, it could be easy or can be more complicated. I mean, the WHO say the patient in which you are confident that this patient doesn't have tuberculosis should be offered prophylaxis. This means the patient doesn't have probable TB. So the best way to look for that is looking for the negative predictive value for different algorithms. And as you see here, the 4 symptoms in patient naive that are not receiving treatment, only asking for the lack of cough, night sweat, weight loss, or fever, can have a negative predictive value of 99% when the prevalence is low. But this is improved also if you have a normal chest rate. So if you have a normal chest rate and the patient is asymptomatic, the majority of this patient will not have tuberculosis and could be prescribed prophylaxis even if you don't have PPD. But I understand that many countries, in particular in the Caribbean, where the tuberculosis in the general population is very low, the prevalence is very low, so there are hesitancy in not doing PPD. And this is fine for patients that are immunocompetent. But look in this study from 2011 in Spain. Spain is also a country with low prevalence, but they could have 35% prevalence of PPD positive among HIV patients when and achieve a negative patient, in high-risk patients. But when you look in HIV patients, you have much lower rate of positivity. But you can have at least half of this in HIV with more than 500 CD4. You see here even the IGRA and the PPD has the similar value. and you can identify some patient with a latent infection. But when the CD4 decreases for less than 300, nobody has a positive PPD, and the IGRA is much more lower than that. Look at the IGRA in less than 100 CD4 doesn't have value because it's indeterminate. So what is the message here? Patient with less than 300 CD4, really you cannot rely, even in the PPD or even in the IGRA, to identify patients that could have been exposed to tuberculosis. And for this reason, you should not waste time and resources doing those tests, but rather directly to initiate prophylaxis. And this was the approach that Brazil took in 2018. They decided directly any patient with less than 350 start prophylaxis and not using those tests. The prophylaxis now is much more easy than before, that we used to use isoniazid for 6-9 months. We have now very short regimens. We have this 3-month regimen for weekly rifampicin plus isoniazid use. It's much more easy to administer because it's once a week. But you can also have 1 month daily rifampicin, isoniazid, and other alternatives. But the 3 months, the weekly doses of rifampicin isoniazid was tested among HIV patient and HIV negative patient. And the brief study with 1 month was also evaluated in 3,000 patients. These 2 studies demonstrated that when using the combined versus the isoniazid alone, the patient has much more chances to complete treatment, and the efficacy in preventing HIV tuberculosis was similar. We need to look for some potential interaction. We need to use also for rare or very infrequent hypersensitivity syndromes like hypotension or low platelets, but it's similar in terms of safety. Remember that we cannot use rifampicin isoniazid in pregnancy or children less than 2 years. This is what it is. It's very easy to administer. It's the isoniazid rifampicin co-formulated tablet, only 3 pills a week, once a week during 3 months. You can add vitamin B6 just in case to prevent neuropathy. Or if you use the 1 month regimen, you will need to use the rifampicin alone plus isoniazid plus the vitamin D. The cost is a little more than expensive than isoniazid, but when you estimate the cost of monitoring the patient during 9 months and the cost of transportation, the DOT, the cost is much lower. And this is something that can be feasible. You can see here how even Guatemala, this is one of the poorest countries in Latin America, is increasing the number of patients receiving rifampicin isoniazid in new HIV patients across the years, with a big impact in this last year. And the combination of rifampicin isoniazid has been used now in 12 countries, including some countries in the Caribbean. For reducing the burden, also we need to be, what is the impact of the treatment? And unfortunately, here we see that the patient with TB, HIV perform much more worse than other patients, than the general tuberculosis patient. And this is because many people die. And 21% of the people dying are dying because they are diagnosed very late in the natural history of the tuberculosis and the HIV. They usually go to the clinic very emaciated, in very bad situation, just to be diagnosed by for HIV and for tuberculosis at the same time. 14%, a little more than in the general population, is loss of follow-up. And for this reason, we need to really improve our support services to engage those patients and recover those patients. And the third goal, that they reduce the burden of HIV and patients with TB, is incredible that still today, 20% of the tuberculosis patients that are linked to the health clinic during 6 months finish the TB treatment without knowing if they are HIV or not. So only 80% of the patient knows what is the HIV status, and as I said before, 11% are informed they are positive. And the life expectancy among this 11%, if they don't initiate very early antiretroviral treatment, is very, very different. So for this reason, we need to continue working with the TB clinics to allow them to make the HIV test, or we should be able to provide HIV cell testing to the patient to be able to have access to the HIV test. And also we should include in the follow-up and the electronic information system in the TB management alerts and reminders to for HIV testing for those patients where the status is not identified. And this is something that is doable in particular in the Caribbean. Let's do the second part of the talk to talk about some clinical characteristics for screening, diagnostics, and treatment. The recommendation of the WHO is that any patient with HIV should be systematically evaluated for the presence of TB. There are, as I said, the 4 symptoms, cough, fever, night sweats, and weight loss, can be used to identify those patients that really need a very formal evaluation with experts. But and also the protein reactive or the X-ray can orientate those patients that probably has TB, so that we need to make more effort to bring those patients to the expert test or the use of molecular tests. The molecular test should be used instead of the bacilloscopy because it's been demonstrated that is much more effective. But you can also use the culture, but that is more or less similar to the molecular test, but in many countries in the Caribbean, it's not available. Regarding the symptoms, as I said before, the symptoms are very good for, say, who doesn't have tuberculosis, but are not very good to identify who has tuberculosis because can be sensitive, but the specificity is low because they can have other opportunistic infection. And for this reason, you cannot start treatment based only in symptoms. You always need to do additional tests to look for tuberculosis. And those tests are the X-ray and the molecular test. The characteristics for the X-ray are very variable and depends on the status of the infection and the status of the immunological situation of the patient. You can see here the primary infection as a tuberculoma in a patient with good CD4. You can have a typical dissemination bronchoalveolar that we can see in patients with high CD4 also, or cavities that we can observe in patients with high CD4. This is a calcification that doesn't orientate to active tuberculosis, but rather that this patient could have had tuberculosis in the past, and this tuberculosis can resolve, and this can be seen also in the pleura. And if the patient doesn't have active tuberculosis, this kind of patient requires also prophylaxis. And finally, on patient with low CD4, you will have the lymph, the mediastinal lymph node or the cervical nodes, and also the miliar pattern that can present. I mean, that is the hematogene dissemination of the tuberculosis in the lung. So, although the X-ray are not easy to read and are not easy to be implemented in different places, We have now different innovation that can be implemented in mobile settings. And this is one of the most recommended intervention now for the WHO. When you use this kind of digital X-ray that has readers with artificial intelligence, this has a sensitivity similar to the X-ray read by radiologists for detecting radiologists with high risk of tuberculosis. So this can be implemented in the field. You see here in Paraguay, they were to prisons to see what is the situation of the patient, the IMATs in the patient, and you can follow the algorithm very easy. The X-ray is negative, the patient can receive the prophylaxis. The X-ray is positive, this required the expert, and this expert will define if the patient needs treatment in the same day. And they could do this in indigenous population and in prison in Paraguay, see, with a very big numbers, and they detected 20%, more than 20% of positive radiology suggestive of tuberculosis. They could perform in almost all those patients the expert, and they could identify and the number of patients that were 3% and 9% in different populations that had tuberculosis and could start treatment. So it's really something that can expedite the management for the national program. When we use expert as a molecular test, we need to remember that this is not only in the sputum that we can use it. And this is good for sputum. We can use TrueNAT or expert for identify the tuberculosis, to identify the tuberculosis resistant or not to rifampicin. But we can also use in urine and lymph node and peritoneal fluid and CCF, and in children in gastric aspirate, pleural fluid, etc. So, and we can also do aspiration punction in lymph nodes and have very good results. So one of the limitations of the expert that is that cannot be very positive in patients with disseminated TB can be solved using the expert in other areas. The other rapid test that we should implement in patients with tuberculosis and with HIV is the use of the LAM. The LAM is one strip that can be used in urine and demonstrated in Africa in this study, randomized study, that can the possibility to reduce 17% the mortality among patients that HIV patients that are admitted in the hospital with any symptom of tuberculosis. So for this reason, the WHO recommend now the use of LAM for all the patients with HIV that are presenting with any of the TB symptoms, independently of the CD4, or if the patient doesn't have one of the cardinal TB symptoms, should be using with patients with less than 100 in all the ambulatory patient with less than 100 CD4, or all the admitted patient with less than 200 CD4. So this is a very quickly intervention that can have a very impact in the mortality. And for this reason, the PAHO is proposing this integrated screening for advanced HIV patients that were recently diagnosed, or patients that are re-engaged and has any symptoms. So those patients should have the standardized screening for crypto, histo, or tuberculosis with a rapid test for histo, rapid test for crypto, and rapid test for tuberculosis, and also the expert if has any potential fluid or sputum to be studied. And if the patient doesn't have symptoms, is really asymptomatic but has less than 200 CD4, we are exploring the same algorithm in several countries, in particular in Paraguay, and now in Guyana also. We started in Guyana and in Trinidad and Tobago. This is the result in the Paraguay study, 492 patients evaluated, and we can see here that we detected 43 cases of histoplasmosis, 52 cases of cryptococcosis, and 92 cases of tuberculosis. And you can see here the contribution of each of these different tests in the diagnosis. So only 20%, 29% had both tests positive, so we could detect 24% more with expert and 46 more with LAM, and most of those patients were with less than 100 CD4, as you see here. So it's critical to use these two tests combined. And it's very critical because the mortality for HIV people with opportunistic infection is much more higher than mortality for patients without opportunistic infection, and the possibility to treat those patients to avoid this mortality is always present when we use this. So how we should address the new HIV patient? In the first visit, we need to do a medical history of the TB exposure or treatment, the clinical evaluation to look for cough, fever, weight loss, night sweat, and if the patient has any symptom, we should do expert plus LAM, the checks X-ray, and if available, also the protein is reactive, and if any of those is positive, we should also, even if the patient doesn't have symptoms, we should do the expert and the LAM. And finally, if the patient is asymptomatic, we should use LAM, even if it has low CD4. Finally, we can rule out tuberculosis based on the absence of symptoms. And if the CD4, if you have access to the CD4 is high, perfect, you can do the PPD, and the PPD is positive, you should offer prophylaxis. But if the CD4 is less than 350, this patient could be an allergy, so you should consider offering the prophylaxis anyway, because the risk of tuberculosis remains high. The treatment has been the same treatment for the last 50 years. It's a 2 months for drug or 4 drugs 2 months. It's recommended that this drug to be administered in a fixed dose combination, that the administration of the anti-tubercular treatment will be daily for HIV positive, not intermittent, and it should be at least 5 or 6 doses per week. It cannot be 7 days a week. However, there are some new information and new recommendations that there are some specific tuberculosis cases or patient that doesn't have severe TB, that has a CD4 more than 100 and are not pregnant or breastfeeding women, that can have a shorter regimen than the traditional 6 months. And this shorter regimen for people with 12 years or more is based in isoniazid, rifampicin instead of rifampicin, moxifloxacin instead of ethambutol, and pyrazinamide. With this 4-drug regimen, the efficacy is similar to the traditional 6-month regimen. Also in children, we can continue using the traditional regimen, but in children that has a non-severe TB, that is only based, the diagnostic is only based because it has a peripheral lymph node or intrathoracic lymph node, those patients can use 4 months instead of 6 months. And there is much more evidence for this second option in children. For patients with resistant tuberculosis, remember any patient with an expert positive that shows resistance to rifampicin should be evaluated for the presence of additional resistance with the other cartridge for multi-resistant tuberculosis, or sent to the culture to the reference center to see if this patient is multi-resistant or not. But if the patient has multi-resistant tuberculosis, we have now treatment that can be shortened to 6 months. And those regimens are based in bedaquiline, proteonamide, and linezolid. I know that is more complex to have access to this regimen, but you can put in contact with the Ministry of Health, with the Pan American Health Organization to try to facilitate the access to these drugs. Patients need to be monitored at least monthly while they are receiving treatment for tuberculosis, in particular for weight, symptoms, the development of iris, and some different countries have different regulations in terms of laboratory that require it to be performed in each visit. The WHO doesn't recommend any specific laboratory for follow-up, but obviously if the patient has gastrointestinal symptoms, a liver panel should be performed immediately. The WHO recommends to repeat vacilloscopy at the 6 months. Sorry, no vacilloscopy, to repeat culture at the 6 months if the vacilloscopy is positive. And remember, the vacilloscopy should be used only for follow-up of tuberculosis cases, not for diagnosis. For diagnosis, better to use expert, but for follow-up after the 2nd month, we can continue doing once a month to see when the vacilloscopy is negative and the patient to monitor the curation. Finally, we need to provide antiretroviral treatment, and there are some contraindications and some interaction between antiretroviral treatment and rifampicin. We cannot use lopinavir or darunavir with rifampicin because produce much more toxicity. So the proposal is to use dolutegravir to duplicate the doses of dolutegravir if the patient is receiving TLD in the morning. An additional dose of dolutegravir alone at the night will be necessary until 2 weeks after the patient stopped the rifampicin treatment, because the induction of the rifampicin persists at least 2 weeks. There are some information about moderated interaction with TAF. Probably is not critical. Maybe the majority of patients can continue with the regimen with TAF if they are receiving. But if the patient is obese or the patient is not fully suppressed, we should consider to switch this TAF to tenofovir or abacavir. So, in summary, we need to remember that we have 3 different types of tuberculosis. Tuberculosis with high CD4, the tuberculosis with very low CD4, and the intermediate patient with more or less CD4. So, in the patient with high CD4, the tuberculosis will be pulmonary. Their X-ray will show cavities or will show pleural effusions. And the expert will be, and the sputum will be positive, but the LAM will be negative because there is a very few dissemination in the blood. In the other side, the tuberculosis in patients with very advanced disease is disseminated. In the X-ray, you will not see anything, or you can see miliary tuberculosis. The expert will be negative because it's not in the lung. The lung will be positive. And those patients, in particular, if has less than 100 CD4, will have a high risk of iris. This means of inflammation once that the antiretroviral treatment starts. This inflammation can be, in particular in patients with less than 50 CD4, can be reduced with prednisone. And this is the only trial supporting this intervention. Is 240 individuals with 49 CD4 receiving prednisone 40 milligrams for 2 weeks, followed by 20 milligrams for other 2 weeks versus placebo. And you see the reduction of iris was the 39%, from 32% in the group of prednisone and 46% in the group of placebo. This is very good for the patient. The patient feels better, doesn't have fever, has better quality of life. But unfortunately, this small study couldn't demonstrate any impact in mortality. And so we need more information to be sure that this is a formal recommendation for everybody. But at least you can look for patients that with very low CD4, you can keep this in mind in case the patient starts with iris that typically occurs after 2 or 3 weeks of initiation of the initiation of antiretroviral treatment. The efficacy of the dolutegravir is demonstrated by the inspiring trial in which I had the opportunity to participate as a site when I was working in Argentina. And this trial wanted to evaluate the efficacy of dolutegravir PID in patients with naive with tuberculosis. The study, even it was not powered for be a comparative study between dolutegravir and efavirenz, could show that the efficacy of dolutegravir was more or less the same. This small difference here is based not in failure, in virological failure, rather in loss of follow-up of patients. And the biggest difference between dolutegravir and efavirenz was not the efficacy itself, but was the potential of produce resistance. As you say, patient with tuberculosis has a lot of vulnerability, and many of them stop treatment during the follow-up. And this, you can see this 26 years old male that started the treatment with efavirenz. He could suppress the viral load, but stopped antiretroviral treatment, so the viral loads increased. And given the long half-life of efavirenz, when the patient failed, the patient have already developed many mutations to efavirenz. So this patient had to be switched to other second-line treatment. Differently, the patient, this was a patient I was taking care of, was a very chaotic state life, stopped treatment many times during the follow-up, but always resuppressed with dolutegravir. And when in the second time the patient presented high viral load, the resistance didn't show up any mutation to dolutegravir, showing that it's much more stronger and robust against the development of emergency mutation for resistance than efavirenz. And for this reason is what we are switching all the patients to dolutegravir. This is the last slides are the guidelines that you can check in the WHO or in the PAHO website. You have the consolidated guideline, the service delivery guideline, the guideline for HIV testing services, and the management of advanced HIV disease, but also the guideline in key population, because many of our patients in the TB program that has HIV co-infection with TB will be or will belong to key population, men having sex with men, transgender women, or drug user. And there are some specificities that if you are working only in tuberculosis, you should be aware of, and you can consult in this consolidated guideline. This another new policy brief is very important because it's about the patients that are seriously ill and admitted to the hospital because suspicion of tuberculosis. You need to see that 20% of the patients that are admitted in the hospital with HIV die, that 20% that is successfully discharged from the hospital is readmitted in the first year because couldn't comply with all the follow-up and didn't have as much or strong social support for complying with the treatments. And from these patients, 14% will die within a year of the discharge. So it's very important to know that we need to really pay attention to not only diagnose people in the hospital, but really strengthen the support services after the patient is released from the hospital. And this include assess in the emergency room for the presence of tuberculosis, refer very quickly patient for other facility when you cannot solve the problem in the facility, diagnose tuberculosis with LAM, an expert in all the patient that has symptoms in the clinic, offer this kind of tests on empirical and even empirical treatment, treat the patient, initiate antiretroviral treatment in the hospital, no wait until the patient is released, and plan very carefully the discharge to ensure a good communication and follow-up of the patient. This is the list of recommended tests for advanced HIV patients that you can see in the guideline in this policy brief. Basically, the LAM, the expert, the crypto and histo tests for patients with less than 100 and 200 CD4, the cotrimoxazole prophylaxis, the prophylaxis for tuberculosis, and the rapid initiation of antiretroviral therapy. People with TB like much more than HIV to do guidelines. So you have here all the guidelines from the WHO TB, Stop TB strategy and the operational handbooks for the implementation of the guideline. And also in summary, we need to work together with the TB program. We need to implement TB prevention and infection control in healthcare setting. We should evaluate all TB patients for HIV infection and also all the HIV patients for TB infection. We should offer prophylaxis, at least, I said 350 before, but at least to those with less than 200 because it's a critical patient that will be dying of TB if they don't receive, are not diagnosed or prevented. We need to improve the screening for the combined TB, histo, and crypto, and we should initiate antiretroviral with dolutegravir within 2 weeks as early as possible in patients with tuberculosis and HIV. Everything is in this online course that is in the virtual campus in Spanish and English. Please, it's free and provide a certification for Pan American Health Organization. So be sure to look in Google for clinical managed TB HIV PAHO and you will be able to find it. And thank you very much to Pedro Bedillo from the TB unit and Monica Rondon and all the team in Washington and obviously all the people from PANCAP, in particular to Shanti. Thank you.
Thank you. Thank you very much, Dr. Omar. It's always a pleasure and a treat to listen to you present. Always very, very practical, very comprehensive, and very evidence-based. And so I know you shared this slide with the HIV guidelines, and then the final slide spoke to some of the TB guidelines, but I see that we do have quite a lot of our colleagues from the TB programs online. And I think the report that you also shared, your very first slide on the Global TB Report 2023 will be a good one to also to take a look at as well. It is very clear that we're making good progress, but it's also clear that there are gaps. And so the deaths attributed to TB HIV continues to be high, not just globally, but also in Latin America and the Caribbean region. Thank you, Dr. Omar, for pointing out the missed opportunities for TB prophylaxis, being able to share with us the weekly doses, the TB prophylaxis regimen using weekly doses with rifapentine. I particularly like your slide on the research that was done in Spain, where it looked at CD4 threshold and the sensitivity of the different screening tests. And so the message, as you said, would be, you know, the question and the message is, what is the value of doing these tests if persons have low CD4 threshold rather than moving directly to prophylaxis? But also building on that, I think all of the new testing modalities that you've shared have been really important. The innovation in mobile X-rays, the use of LAM testing, export testing, and how we all bring that together to be able to make the diagnosis. And I particularly like the programmatic data that I think it was from Uruguay that you shared. That was really, really demonstrated the impact of using these tests in combination. And finally, I think I appreciated the fact that you talked about the different regimen in terms of TB treatment. The 6-month versus, well, not necessarily versus, but the 6-month and the 4-month treatment, and both of them having similar efficacy. We have a few minutes left, colleagues. I do see some questions and some comments in the chat. Dr. Omar, you can also access these. I don't know if you want to go through them for me, or do you want me to take them for you?
I don't know why I cannot see the chat.
Okay,
So,
all right. So, in fact, we don't have any questions, but we have a comment from Dr. Kwesi Grant, who works with a TB program in Guyana, that's saying that in Guyana, they have two of the digital x-rays, the slide that you shared on the digital x-ray. One is in the hinterland, and there's one in the main referral hospital, and they're hoping to use AI along with a digital x-ray to be able to strengthen radiological diagnosis. Dr. Grant is also saying that in Guyana, the National TB Program with their National AIDS Program have commenced piloting 3HP as TB prophylaxis, TB prevention treatment for people living with HIV. So good progress, colleagues. If
it's
anyone else would
incredible.
like to share,
Yeah,
if
in
anyone else
Guyana.
would like to, yeah,
Yeah,
to share
because
what you're doing, go ahead, Omar.
yeah, sorry. No, I say that in Guyana, this is incredibly good news because the access in some part of the country, in particular in the rural areas, you can move with this X-ray very easy and have the result in the same time, and maybe you can adapt an expert in some mobile van. It will be very practical to do this screen once a year or every 6 months in different miners and lodgers, etc. So great advance. Thank you very much for sharing.
Yeah, thank you, Dr. Omar. I see there's one comment from, similar comment from Dr. Grant and Dr. Ruth Ramos. Congratulating and thank you, Omar, for a really good and informative webinar. And colleagues, yes, we will share the presentations as we always do at the end of the webinar. Omar, I just also wanted to sort of touch on their recommendation in terms of multi-resistant TB, and I do appreciate the point that you made that if we use expert TB and there is resistance to rifampicin, then we should be looking for other resistance. I think that's an important point. It does not stop with resistance only by expert TB. Any comments? Any additional comment on that?
Yeah, there is an expert cartridge also for extended resistance that you can use in tandem. If the first traditional expert ultra is demonstrating resistance to rifampicin, you can use the other cartridge for assess resistance to second line drugs. So it would be much more easier for countries that doesn't have national reference labs to have this one. So I wonder if CARFA has access to this cartridge or not, but it's something that I can ask to Pedro, that he is and Ernesto Montoro for that they are providing technical support for that.
Yeah. Yeah. Thank you, Mar. We can certainly check on that. And then the final point that I wanted to mention, which I appreciated as well in your presentation, is in terms of the treatment, the 2 + 4, 6 months, and the alternative of the newer regimen using rifapentine and moxifloxacin for 4 months with similar efficacies. So I think that was great as well.
Yeah,
We are at
there's also a comment in here. I mean, it's much more easy once a week because it's co-formulated presentation of rifapentine with isoniazid, so it's only 3 pills a week and once a week. But there are some situations where you can use 1 month more easy, even though it's the rifapentine that you need to use is in separated pill when you need to use for 1 month. And this is for example, in prisons, you have the patients there for 1 month. It's more easy to do that than for 3 months. But depend on the country, and you know that it's difficult to buy different drugs or different presentation of the drugs. So probably the country should decide which regimen will be using, if using the rifapentine isoniazid once a week or using daily, because it's different presentation. I would recommend, even though I would recommend weekly, because for the patient are more easy to tolerate.
yeah, better with compliance. Yeah, all right, we are at 12 No. So there are no other questions at this point, no other comments. Colleagues, we will send the presentation to you. So let me go ahead very quickly and close today's webinar by saying thank you. Thank you, Dr. Omar, for, again, very comprehensive as usual, relevant, practical, evidence-based. And thanks to PAHO for the continuing collaboration to be able to support PANCAP in its mandate to build capacity among our healthcare providers and national AIDS program managers. Thank you, Dr. Wendy, our PANCAP director, for bringing remarks to our attendees this morning as well. Let me say thanks to all of our attendees for joining us. I know you have been with us in this journey over the last 3 to 4 years as we have been conducting these webinars on a regular basis. Do join us. Our next webinar is on Thursday, the 8th of February, same time at 11 a.m., where we'll have Dr. David Coren, who is an adjunct professor in the Department of Pharmacy Practice at Temple University, will provide us an update on the interpretation and management of HIV drug resistance. Really very exciting and interesting lecture from Dr. David Coren. And so with that, thanks again, colleagues. Do have a good rest of your day and see you next time. Take care, everyone.